For every one of these episodes, can we just come on and say address inflammation? And then
Yeah.
that's it. We don't have to record anymore. Just
Just,
focus on anti-inflammatory diet and you're good.
yeah, we could just do a lower systemic inflammation. And then I don't know what the sound is for a podcast, but basically a mic drop right after that.
Yeah. And then we're done.
And we're done. We're out.
Hi, Tina.
Hey, Leah, how's it going?
It's a beautiful sunny day here in Portland, and we're going to be talking about bone health.
I'm excited to talk about this. I feel like it's one of those things that people can really grasp, understand, and then they can do whatever's needed for their own bone health because it's physical and it's not too abstract. It's easier to understand than some other things that we talk about.
Kind of across the board. I mean, anyone who's been through treatment for cancer in some way, their treatment may possibly have affected bone density through a number of different mechanisms. And so, yeah, hopefully people get stuff out of this episode.
And can I add, this is not just cancer care. This is inevitable. If you live long enough, you have bone loss after a certain age. So a lot of things that we're going to talk about would be relevant for everybody as we age.
Oh, yeah. Oh, for sure. But before we do start, I wanted just to kind of talk about the song, our unofficial theme song for today. And it was a song I'd never heard of. I was like doing my search for songs with bones in the title. And I came up with a song called The Bones by Maren Morris.
Okay. Of course, I've never heard of that.
It's a pretty good song. I think you would like it. And what I liked about it is they're not actually, she's not actually singing about bones, but she's referring to the bones as like a foundation of a relationship. And I mean, the bones are the foundation of our body, right?
Yeah, at least the mechanical aspect.
Yeah. I mean, it keeps us upright and ambulating and whatever it is that bones do. We're not rubber chickens here.
It's a funny visual, picturing a rubber chicken.
That's what came into my head. So the most foundational part of bone health would be understanding how is bone made. I mean, in order to know how bone gets lost, it'd be good to know how bone is made.
Yeah. So I think a lot of people probably imagine that once you grow into an adult, you have your framework, you have your skeleton, and there you are for whatever number of years or decades you're on the planet thereafter. But in fact, it's actually much more dynamic than that. It's not a static thing. It's constantly being broken down and rebuilt. And I think that is underlying everything we're going to go ahead and talk about today, which is your bones, as we speak, are being chewed up by one cell set called osteoclasts, and bone is being laid down by another set of cells called osteoblasts. So the rate of each one determines whether you're building bone. So you're building bone when you're young, of course, and through your 20s even, you're laying down bone. That means your osteoblasts, which lay down the bone, are functioning faster, and there's a good number of them relative to the breakdown, the osteoclasts. So after about the age of 35, it switches. In women, anyways, it's 35. So after the age of 35, the osteoclasts begin to function at a faster rate, or their population is higher, however you want to say this, but you basically break down bone faster than you can lay it down after 35.
So young.
Yeah, we lose a large amount of estrogen as women when our estrogen stops being made, right? So estrogen is one of those, we're going to talk about hormonal influences, but we kind of think about bone loss as a menopausal, perimenopausal, postmenopausal thing that happens. That is called an estrogen bone packet. In other words, if it's a natural menopause over the 3 to 5 years that it takes to go through menopause, you lose a packet of bone rather precipitously, and then you level off again. Because when estrogen goes away, you lose a bunch of bone very quickly, and then it levels off. You don't continue on that trajectory on a downhill slope. So the percentage-wise, you might lose a larger percent when your estrogen is no longer being made by your ovaries, or you go through a surgical menopause, a chemical menopause, which is chemotherapy can put some people into menopause. So that particular packet of bone is lost during that time, and then you kind of resume the pre-menopausal state of bone loss.
So even when someone goes through menopause naturally, you still have a short period of time that the bone loss occurs.
Yes.
Interesting.
So if you're losing, say you're losing 1% a year normally, during a time of estrogen deprivation or deficiency, you might lose 2% or 3%. You're
Okay.
going to basically, the decline is going to be faster. So these osteoclasts and osteoblasts are constantly chewing up bone and laying down bone, chewing up bone and laying down bone all of our life. And we can affect it when we're going to talk about what affects bone health. But just remember, what we're doing ultimately is influencing this balance between the osteoclasts and the osteoblasts. Now, I probably should give you the way I've always remembered osteoclast, because these two words are so similar. There's only
And they
one
don't
letter.
make sense. Like you think osteoblast is like you're blasting a building and it's like being destructive. I know these, I've talked to you about this before. Like those words just throw me every time.
Yes, yes. The osteoblasts are actually laying down bone, and
They're building bone. The blasts build bone.
they're building the bank of bone. There's a lot of B's that you can, a lot of alliteration we can use to remember osteoblast, are building bone bank, and the osteoclast, think of the C like a Pac-Man, right? So a C like the Pac-Man at the arcade. We used to play Pac-Man, right?
Back in the day.
That's right. Back in the day when we put a quarter in. So the little Pac-Man eats the bone, right? So you have a C for osteoclast. That's how I have always remembered it.
Perfect. I feel like we need the Pac-Man music in the background. So I think it's a perfect time to start talking about risk factors.
Yeah. So risk factors in general for osteopenia and osteoporosis, which we probably should define. So osteopenia is defined as a certain amount of bone loss reflected on the DEXA scan. And without going into too much detail about what these scores mean, there's a T score and a Z score on every DEXA scan. And the T score reflects one's bone mass compared to a healthy 30-year-old female, if we're getting a female DEXA scan. And if it's more than -1, so if it's between -1 and -2.4, it's osteopenia. It reflects a certain amount of bone loss. If it's 2.5 or below, then it's osteoporosis. So it means there's even more bone loss. And all of this is relative to a T-score of 0, which is a healthy 30-year-old female skeleton.
That is a perfect explanation. And for most people, I think, well, it's mostly women because women are the ones who are most susceptible in a general population to bone loss. I believe the evaluation starts after the age of 65. But when you throw cancer treatments into the mix, then it is, it's sooner. So I know with aromatase inhibitors, it's every 1 to 2 years. Mm-hmm. And I believe that's probably based on other risk factors. So 2 years might be for someone who's younger, but then if there are other things like age and smoking, and we'll talk about all of those, then maybe that's why it increases to every 1 year. And then for patients who are on androgen deprivation therapy, it's every 2 years.
So so if there is a low level of estrogen or testosterone, respectively, in the two drug classes you just mentioned, androgen deprivation.
So that's typical in anyone who is undergoing treatment for prostate cancer.
Yeah. And, the naturopath in me goes a little farther. I'm actually pro DEXA scan as a preventative measure, basically just all women in particular from the ages of between 50 and 55, depending when one is able to do it or what they've gone through as far as menopause. I think everyone should get a baseline DEXA scan. That's my recommendation to most people. And insurance often doesn't cover it, but it's a glorified X-ray. So the cost is usually not a lot of money compared to having osteopenia, osteoporosis over time. And I say that because there's so much we can do to prevent bone loss. It's very hard to reverse it as we get older. It's one of those things that if you already have a tendency to low bone mass, you can do a lot to prevent further degradation of the bone. That's very achievable.
Right. And these risk factors apply to pretty much everybody. I mean, a lot of people will have maybe one risk factor, so it is it's a great monitor.
Mm-hmm. Mm-hmm. As far as the DEXA scan, you mean?
Yeah, the DEXA scan could be a great way to monitor. And like you said, we think preventively. So why wait for it to get to osteoporosis? Why wait for a bone break?
Yes. Unfortunately, that's usually when I see a DEXA ordered is after someone falls and, breaks their wrist or, has some other accident and breaks something. And then they'll get a DEXA scan eventually. But like I said, I think it's a good preventative thing to do for everybody.
Speaking of bone breaks, that reminds me of a little story. When I started treatment, I underwent one cycle of chemotherapy, and then I received an injection of goserelin, which shuts down your ovaries. And I believe that I received 2 of those injections over the course of my chemo.
Mm-hmm.
So I complete treatment, and then I think it was that winter. I was in Arizona, so it's hard for me to imagine because it was like sunny. So it could be at any time of year. But that winter for my birthday, I got a bicycle so I would be more active.
Okay.
And we used to ride our bikes to go get brunch. So we'd kind of ride through the preserve and we'd go somewhere and grab brunch. And because that was my motivation for exercise was food.
That makes sense. Okay.
And we were coming back from brunch one day and I was startled on my bike and I fell off. And it turned out I broke my foot. I broke a bone in my foot. My foot was treated and everything. We didn't repeat the DEXA because I had just received one prior to even starting treatment. And then at the 2-year mark, I got my DEXA and it showed that I had osteopenia. So that just always makes me wonder, those 2 shots of goserelin, is that what sped it up?
Mm-hmm.
Because within the 2-year mark.
So if I hear what you're saying, was that DEXA scan that you did at the baseline before treatment, was it normal?
It was totally normal.
Okay.
Totally normal DEXA scan. And then at the 2-year mark, it showed osteopenia. And I mean, since then, I broke my ankle in the same foot. But my last DEXA scan, and it's hard because they were done at 2 different facilities, but my last DEXA showed a little bit of improvement in the bone density. So my oncologist and I were just kind of going with that. like 2 different facilities, but maybe there's something positive in the things that I've been doing.
Yeah. And we can talk in detail about that whole idea of estrogen deprivation. And you also received some steroids during that 2-year period, didn't you?
Yeah. I mean, but it was a very short course. I mean, I just did the steroids during the adriamycin cytoxin. I don't know. Maybe I did do the steroids during the Abraxane, but I don't think so. I think they stop it during the taxane.
Mm-hmm. Okay.
But maybe I got a huge dose when I had my allergic reaction to Taxol, but we digress.
In any case.
In
2 years. In 2 years, went from normal bone to osteopenia.
Yeah.
During treatment.
Enough about me. Enough about me. Let's talk about risk factors. We can talk about me later.
All right. Circling back to the risk factors. So smoking, top of the list.
Yep. So smoking affects bone because it reduces the blood supply to the bone, which, your blood is transporting the nutrients back and forth. So that's part of how it affects it. And then also nicotine slows the production of osteoblasts.
Mm-hmm. Yep. And we're going to constantly go back to that. Like anything that slows down the osteoblasts or speeds up the osteoclasts is going to lead to bone loss. Mm-hmm.
Yeah. And then there's also, I think somehow it affects the absorption of calcium as well.
Yeah. I like to think of it like anything that can lead to a deficiency in the building blocks of bone. I kind of lump those all together. So that could be not enough calcium in the diet. It could be not enough of the trace minerals in the diet. So that's things like silica and boron and manganese, trace minerals that are necessary for the structure. Not enough magnesium, which is a very common deficiency in the United States anyways. Magnesium is often deficient in people. So I think of deficiencies first. So I'm going to say not just low calcium diets, but low mineral diets.
So one of the things that can affect how we even absorb our minerals are certain medications that people take. Mm-hmm. PPIs, proton pump inhibitors. Mm-hmm. People take that for reflux and various other gastrointestinal issues. You need stomach acid in order to absorb nutrients. Yeah. And so you're reducing the stomach acid. And taking a PPI can actually prevent you from absorbing not only vitamins, but minerals that are important for bone building.
Yeah, that's a really good point, because anything that leads to a reduced stomach acid will make the absorption of the minerals less efficient. So, yeah. And the PPIs were never really approved to be used long term. They've just kind of been adopted that way. The idea behind all of these stomach acid reduction agents, whether it's a PPI or a H2 antagonist, doesn't matter. If it reduces the stomach acid, it was really approved for a short course, 2 weeks to 2 months, not in perpetuity.
I mean, people are on those for years.
Yeah. And the links, there's definitely studies showing the association between taking those PPIs long term and having higher risk of fractures due to low bone density. So yeah, that's been a proven risk factor for sure.
Other things that cause malabsorption, there are other medications that can affect the absorption of minerals, but then there also are conditions like celiac, inflammatory bowel diseases, certain treatments for cancer, surgery where part of the GI system is removed. You will be affecting the absorption of some vitamin or mineral that may in turn be what helps to build bone.
Yeah, because you have to remember that the stomach is needed for the acid, and the small intestines are really where it's all absorbed, right? So most of it in the upper part, the very first foot or so of your small intestine, but essentially the first few feet, up to 6 feet of the small intestine, is where most of the absorption of our nutrients takes place. So any surgery that has removed any part of the intestinal tract can definitely affect absorption.
Other things like alcohol intake, a sedentary lifestyle.
Yeah, and that'll be the polar opposite of exercise, which we're going to talk about in a little bit, and how exercise helps. So the extreme opposite of exercise is a sedentary lifestyle.
Right. And some people aren't able to move around as much. What's always fascinating is astronauts, right? Being an astronaut and being up in space, that's a risk factor.
Yeah. Anti-gravity, because gravity is one of the ways that our body knows to build bone. So when we walk, our bones have this little vibration that goes through them, and that actually signals the osteoblasts that bone is needed for our structure. And that's ultimately why a lot of times you're going to hear about walking in particular, or jogging or running, whatever you're capable of, is very good for bone health.
And then there are hormone issues, right?
Yeah, hormone issues like high thyroid function. So too much thyroid hormone. And that could be people taking too much as a replacement dose. So clinically, they have a low thyroid condition, but they overdose the medication. That could lead to bone loss.
Another aspect of something that's diet, and I think it's a big surprise for some people, is drinking a lot of colas.
Yes.
And it's not like soda or pop across the board. It's colas, and it's definitely a culprit.
Yeah, it's the phosphoric acid in there. So if you look at the label of a carbonated beverage and you see phosphoric acid, you're going to have to buffer that phosphoric acid with calcium in the body. And if you're having that and you're doing, what wasn't it on Laverne and Shirley? Didn't Laverne drink Pepsi and milk?
Oh my gosh.
Unbeknownst to her, she was mitigating the effect of the phosphoric acid.
No, you just pulled that out of nowhere. I'm so impressed. Wow.
Yeah. In any case, she was mitigating the effect of the phosphoric acid because basically when you drink the phosphoric acid, you have to find calcium somewhere in your system to buffer that acid. And an experiment you could do at home is, if you're eating any kind of poultry, especially like a small bone from a chicken, you can put it in cola or Pepsi for a day or two, then pull it out and you'll end up with a rubber bone because all the calcium has been sucked out of the bone and you end up with just the collagen left. And, it's a good kind of home science experiment for the kids.
Have you done this?
Yeah, you can do it with soda pop and you can do it with vinegar too. And I actually, this is going to sound odd, but I actually had people do this. They would take their vinegar and put a bone in it. And that way, when they would use their vinegar in cooking, they were getting calcium with it as well.
A little cooking tip: Pepsi and milk and vinegar.
Yeah.
Vinegar and chicken bone.
Where have we gone
Cooked chicken
in this podcast?
Bone. The chicken bone has to be cooked.
Yes. No raw chicken bones.
For more recipe tips, tune into the Cancer Pod.
Yeah. What I use the kitchen for and what you use the kitchen for are two different things.
Yours is a laboratory. Okay. So again, let's come back to hormones because that estrogen loss, the testosterone loss, like that is what we see a lot with cancer patients.
Mm-hmm.
Chemotherapy also has an effect on the cells that build bone. And in addition to chemotherapy, there are certain cancers, multiple myeloma, that affect bone as well.
Mm-hmm.
But I think, the hormone part is a really big contributor.
It is. I mean, it's relevant to cancer care. And if you age, it's somewhat inevitable, right? So you could be taking an aromatase inhibitor or something that blocks testosterone, one of those androgen deprivation drugs, and that will reduce the hormones. Or you could just be elderly, and with every decade of life, we produce less and less testosterone and less estrogen. So either way, what you're looking at is both testosterone and estrogen lead to longer life of those osteoblasts. So there's more osteoblasts. Also, they, to some extent, block the osteoclasts. So the estrogen and testosterone will block the osteoclast from chewing up the bone. And so when they're gone, the osteoclast gets to run more wild. Another thing that happens with estrogen, I know, and testosterone, I believe, is that there is more inflammation in the bone when that hormone is not present. So if someone is on an aromatase inhibitor or someone is on an androgen deprivation drug or just postmenopausal or past the age of, say, 60 or so, one thing you can do is lessen inflammation in general, and that should have some effect because the process within the bone is still an inflammatory process, and the inflammation is actually higher on the bone surface because of the lack of the hormone. So those are the sex hormone influences, but too much thyroid hormone can lead to bone loss. And of course, steroids, like our own production, high cortisol, a high cortisol state will lead to more bone loss. I think of steroids, our production and the prescription of them kind of under the same umbrella because all of the effects are very similar.
I think of people with asthma. I've had patients who have taken steroids for a really long time because of asthma or because of an autoimmune condition. And they'll take steroids for a really long period of time. And then they kind of notice that bone loss. Another cancer treatment that leads to bone loss is radiation. And so someone may get radiation to a certain part of their body, and then a delayed side effect of that would be bone loss.
Yeah, and that has to do with what you were mentioning. Some of that has to do with the vasculature changing due to the radiation, and some of it has to do with hitting those osteoblasts and osteoclasts at the surface. So there's less potential for restoration of the bone. There's less dynamic turnover of bone in general.
So we covered a lot of the risk factors for bone loss. I think we need to talk about the nutrients that help to build and to sustain bone density.
So I think when people think about bone health, the first thing they think about is their calcium and their calcium intake, right?
Oh, absolutely. Absolutely. And one of the things I think that we have in common is that we both emphasize food sources of calcium because you're getting all the other nutrients that you need for other processes as well. Yeah.
And a lot of the calcium in nature is found in healthy green leafy vegetables and broccoli and
right. It's not exclusive to cow products. And when talking with a patient, I typically evaluate their calcium intake, like their average, some days you might have a little bit more greens or more cheese. And so just kind of take an average of what their calcium intake is. And then that's what I base their supplementation on.
Yeah, because you do want to get it primarily from diet. And this is where if you take a supplement, it is a supplement that you're taking for a safety net to make sure that you get enough. But if your diet is adequate, you could get away with not needing a calcium supplement. If you're not on a medication that requires it or some other reason, you can get enough calcium from your diet. And the recommended total is how much?
Well, the recommended total, which when I double checked the dosage from food and from supplementation, the recommended total is, if you're under the age of 50, it's 1,000 milligrams a day. And if you're over the age of 50, it's 1,200 milligrams a day.
And that's diet plus supplement.
That's diet plus supplement, and that they're not on a bisphosphonate.
Mm-hmm. Diet and supplement put together, upper limit is around, 2,500 milligrams a day.
2,500.
Mm-hmm.
Yeah. So if somebody is on a bisphosphonate or one of the medications that you get when you have, bone loss from osteopenia, or if you have cancer in your bones, you also get a bisphosphonate. The recommendation for that is between 1,200 and 1,500 milligrams a day of calcium.
So slightly more.
Slightly more. Yep. I think one thing that I really want to mention is oftentimes I would see patients who were told by their doctor that they needed to take 1,000 milligrams a day, and they hate taking pills, and they get these big horse pills, these big calcium carbonate horse pills, and they complain because it's so big to swallow, and they just take it all at once. And I have to explain, like, you're not absorbing that much. So calcium is one of those things that smaller doses more frequently is better because you'll actually absorb more.
Yes. Yeah. And the irony of the calcium carbonate in particular is that you need really good stomach acid to absorb calcium carbonate. So that might be fine if you're, young, but we all make less and less stomach acid as we get older. So calcium citrate and other calcium forms are probably better as we age so that we absorb more of it. And we'll never absorb 100% of any mineral we put in our mouth, right? We absorb a small amount of every mineral, whether it's from diet or a supplement. So frequent dosing is your best bet to kind of slowly drip it into the system.
Yeah, because I think that 500 milligrams is like the limit as to what you can absorb. And so you're kind of wasting. I mean, you're just struggling to take this huge giant pill. And then calcium citrate is also really good if somebody is on a medication or has some sort of malabsorption issue.
Yeah, it's less dependent on stomach acid to be absorbed in general.
Yeah.
So I have a story about high dose calcium.
Oh, no. I'm afraid.
Well, it's a cautionary tale.
Okay.
I had someone with osteoporosis who came in and she had spasms in her calves, debilitating spasms. I mean, she was having these muscle spasms in her calves that kept her from being able to walk, and they would happen suddenly. And in the intake, we went through everything she was doing. She's seeing an osteoporosis specialist in Portland who had her on 2,500 milligrams of calcium. And when I asked her about magnesium, she wasn't taking any. And she'd been doing this for quite a while. I don't know how many months, maybe it was a year. And high-dose calcium without magnesium over time will just make any magnesium deficiency that much worse, right? So she had this imbalance between her calcium and magnesium. And I suspected that her high-dose calcium was causing this symptom of magnesium deficiency in her calves. So we just did it intravenously. We just pushed some magnesium right then and there. And she felt much better.
She had like immediate relief.
Immediate relief. Yep. Well, it took 24 hours to really set in. But the next day she called the office and said, "Oh my God, this is amazing." And it was a very simple solution to a simple problem. But she had been suffering for many, many months at that point. And for whatever reason, I don't know if she didn't hear it or it wasn't given, she didn't take magnesium alongside her calcium. So ever since then, I'm vigilant that people take a calcium-magnesium ratio that's at least 2-to-1. So if you're taking 1,000 milligrams of calcium, you're taking 500 milligrams of magnesium.
In divided doses again.
Yes, ideally in divided doses over the course of a day. Mm-hmm.
So yeah, that brings us to magnesium. So what is the role that magnesium plays?
It's also part of the bone structure, right? So magnesium not only acts as a muscle relaxant and it's a cofactor in all sorts of reactions in the body. I think upwards of 400 chemical reactions in the body require magnesium, mostly in the liver, some in the brain. But as far as the bone health goes, it's actually integrated into the bone structure.
And it also helps with the absorption of other minerals. All of the minerals kind of interplay off of each other.
Yeah, and of the two, magnesium deficiency is more common than calcium deficiency, at least here in the United States.
Right. But if you get calcium from dark leafy greens, you're also getting magnesium. And so I think what we are suffering from in the United States is a dark leafy green deficiency.
Yeah, you're probably right. Yep. Well, and the other nutrient we need to discuss alongside the calcium, of course, is vitamin D. D as in dog.
Oh, yeah, for sure. Because that one definitely has a relationship with calcium.
Yeah, yeah. So vitamin D, ultimately, all you have to know is that vitamin D improves the absorption of calcium in the gut and it prevents its loss in the urine. So it basically helps you retain your calcium, absorb your calcium from your diet or supplement, and retain it in your body and not pee it out as much.
And there really isn't an established, like, what should your vitamin D level be? 30 nanograms per milliliter is kind of thrown around as
Hmm.
what the baseline should be. But then when you've been through cancer treatment, I know my naturopathic doctor recommends that my vitamin D level, my baseline is higher.
Hmm. Yeah, and I just want to say that 30 nanograms is per milliliter is 75 nanomoles per liter because internationally, I think they use the nanomoles more like using nanomolar amounts. And as you know, we're really big in Bhutan.
That's right. We are. I forgot about that. No, it is important. Yeah, it is important for me to try to include both of those measurements because we do have a lot of international listeners
Hmm.
outside of Bhutan.
Yeah. Yes, all kidding aside. Although we're not in the top 10 anywhere else but Bhutan.
That's true. It's good to be liked no matter where it is.
The best thing about Bhutan is they have a gross domestic happiness index instead of a gross domestic product. So it's pretty cool to be big in Bhutan.
Oh, for sure. Especially because I don't necessarily think of everything that we talk about as happy. So,
No, that's true. That's true. I'll give you that. So what are the nutrients?
vitamin K2.
Yep.
So it's not vitamin K, which is the one that affects blood clotting that you actually find in green leafy vegetables. It's vitamin K2, which tends to be in fermented products.
Mm-hmm. Mm-hmm.
I know aged Gouda
Mm-hmm.
actually has some vitamin K2 in it, as does natto, which is a fermented soy product common in Japan.
Mm-hmm. Yeah, the vitamin K1 and vitamin K2 are two separate molecules. While they are both for bone health to some degree, vitamin K1 is the one that can interfere with coumadins, warfarins,
Mm-hmm.
the drug class that is designed to block vitamin K. That's what they do.
Right. And that is something that a lot of patients that I had were taking.
Right. So, greens aside, vitamin K2 you can get from fermented products, like you mentioned, cultured and fermented things. Interestingly, a lot of the cheeses make more of the K2 products when the goat or the cow has grazed on grass. It's actually the K from the grass that makes its way into the milk that is then fermented into a vitamin K2.
That's a cool fun fact. So grass fed dairy.
Oh, I'm full of them today.
Again, we need a little soundboard. Fun fact. Fun fact. Okay, that sounded like Wayne's World. It's all that came to my head. So vitamin K2, and not all K2s are the same. I mean, they're not all the same.
No, generally they're designated MK dash and then a number. And that number is what chemically makes different compounds. So they're popular in supplements right now is MK4 and MK7. And MK4 is interesting. I use that in higher doses, much like it's used in Japan, where it's been approved as an anti-osteoporosis agent.
So it's an actual medication in
It's
Japan.
a medication in Japan used for osteoporosis. Its approval is for use for osteoporosis, and it's MK4 that's used there in high doses, milligram doses. And here that's a supplement, not a drug. Also found as a supplement here is MK7, and it's a slightly different molecule, but they're both considered vitamin K2. So K2 is not one molecule, it's a family of molecules. They're called vitamers, MER, vitamers. So there's a bunch of vitamers under the K2 designation.
The one I take is a calcium magnesium. It's like a mineral complex with the MK7 because MK4 is harder to come by.
Yes.
And especially finding a good quality product.
Mm-hmm. It is. I agree. MK7 has become much more popular.
Is there any truth to MK7 being better absorbed than MK4? Like, what's the difference between the two?
I think of them as two totally different things. I think MK7 is enough to ensure that you're not deficient in the vitamin K2. And I think of the MK4 as what I would consider a nutraceutical, like something that's approaching a pharmaceutical, but it's not a pharmaceutical, right? It's a naturally derived agent. So I think of it as a bigger gun of sorts to use the MK4 in high doses than just doing an MK7 in a combo formula or alone to make sure you're just not deficient.
Is there still benefit in taking K2 as MK7?
Yeah, because a deficiency of vitamin K leads to greater bone loss. So in that sense, yes, you want to make sure you have enough vitamin K in your diet or in your diet plus supplements to make sure you're not deficient. So as always with nutrients, I think of it as two different things. Making sure someone's not deficient is different than giving someone a high dose of a single nutrient for a specific task.
And I'll put up a list. There's probably a more comprehensive list of K2 foods besides grass-fed aged Gouda.
Although it does sound delicious.
We could just stop right there. Grass-fed aged Gouda. Love it. There are a couple of minerals that are a little controversial. One that you often find in formulas is boron.
Mm-hmm.
And we often recommend that our patients with a history of breast cancer not take boron over 3 milligrams.
Yeah, that has to do with some old studies that showed boron in high doses led to higher amounts of estrogen and or testosterone in circulation. So I think it's out of an abundance of caution that people not take a lot of boron because it's possible that it creates more hormonal production.
And then another supplement, which I saw a lot when I was doing my training, is strontium.
Mm-hmm.
And strontium would be recommended for patients with osteopenia. Studies have shown that strontium may change the way that the bone appears on a DEXA scan, but there was no reduction in fracture risk.
Mm-hmm. Mm-hmm.
So it's one of those things that I think I kind of compare it to, like, you're just kind of drawing on the x-ray. You're just kind of filling in the bone on x-ray to make it look more dense, but you're not actually helping. And so that's one thing that I often deter people from taking that supplement.
Yeah, because a better picture on a DEXA scan is not really our goal. Our goal is to reduce fracture risk. So yeah, it's important to know that those are two separate things because strontium does make it look whiter. So it looks more dense because it's a denser substance. And I don't know much about this, but I know in Europe, strontium ranelate is approved for osteoporosis, but I don't know what form of strontium that is. Strontium comes in different salt forms. I don't know anything about the drug strontium ranelate. I know what we have available in the United States, strontium citrate, for the most part, is not something that I'm too gung-ho about either.
So if you're listening and you're in Europe and taking strontium ranelate, that is different than what is available here in the US. In the US, it's available as a supplement, and it's not the medication that you're taking. That actually does show to reduce the risk of fractures.
So strontium normally is found in bone, but we get it from whole foods like all the other trace minerals, right? So you do need a little bit of boron, and you need a little strontium, and you need a little silica, and you need a little manganese. But you really should get that from your food sources because they're trace amounts. You don't need large amounts. I would argue if you're eating a healthy diet and it's organic, you should be getting that completely from your diet, not from any supplement anyways.
That's a good point. And I think what you were saying about reducing inflammation overall. So eating a low inflammatory and anti-inflammatory diet that's rich in fruits and vegetables and grains provides a lot of those trace minerals that are needed.
Mm-hmm.
So we covered a little bit of diet. We covered some nutrients. The other thing that supports our bones is it's the big guns. It's exercise.
Exercise. Is this
our song?
Everybody do your exercise and freeze. Do.
Is that a song?
Wonderama.
I didn't watch
Where
that.
were you as a child? Didn't you grow up in front of a TV?
I grew up in Spain.
Oh,
I grew up in Spain. We didn't have that. I missed out on so much American culture.
70s were the bomb, man.
I was watching Laura Ingalls Wilder and speaking Spanish with an adult woman's voice. The first time I heard Melissa Gilbert's voice as a child, like speaking in English. I was so shocked that she had such a child's voice because I was used to her speak.
She wasn't a grown Spanish woman.
She wasn't a grown-up Spanish woman. Okay. Okay. Okay, so we covered the risk factors. We covered the nutrients that are needed to help to support against bone loss. And I think now we move into our big guns, exercise.
Yeah, this is a use it or lose it by definition, right? I mean, unfortunately, you lose bone if you don't use bone. And if you are sedentary or you aren't able to use the bone, they will degrade.
So the types of exercise that are important, we always hear about weight-bearing exercise. So walking, rebounding would be like an extreme, but anything that creates that vibration that you mentioned.
Yeah, vibration, and then anything that builds muscle, because the truism is if you build muscle, you must build bone, right? So if you think of your bicep, for example, and think of it as a lever, you put something in your hand and you raise it up. Well, if you're increasing the size of your bicep, you have to increase the bone underneath, because eventually you would pick up something that's too heavy for the bone to handle and you would break. So you have to be able to have enough bone for the muscle structure of the body. So everything that builds muscle will build bone.
And when you're doing resistance exercises or, weightlifting or whatever it may be, even yoga. I mean, yoga has been shown to help to maintain or increase bone density. When you're moving like that, your muscles, your tendons, they're all pulling on the bone, and that pulling on the bone is what stimulates.
Yes, it's very responsive to the mechanical stressors, right? Whether that's gravity making us vibrate with every step we take, yoga and the pull on the bone. So it's responding to the mechanical stressors and saying, oh, you need me. You're demanding this of your bone, so your bone responds. And this is interesting. The way that we now know that muscle creates its own cytokines. And we often talk about cytokines in the context of inflammation, but cytokine is a fancy word for a messenger molecule.
Yeah, it's a signal.
It's just a signaling molecule. It's a fancy name for a signaling molecule. So the muscle builds these signaling molecules. One of them is called myokine. One of the things that happens with this myokine, which is a type of cytokine that is actually made by the muscle itself, is that goes out into circulation. When it finds its way to the bone, it actually stimulates the bone growth. So we now know the chemical messenger that tells the bone to grow are these molecules that are made by the muscle that go and tell the bone, we need you. We're going to build up.
Myokines.
So can kind of think of muscle as strange as it sounds. By definition, that makes it an endocrine organ, because it's innately creating a messenger molecule that is having effect on a distant tissue. So by definition, it is having an endocrine effect.
I learned so much, Tina. Tina's geek out moments. So yeah, we already talked about astronauts and how gravity is important when building bone density. For people who aren't able to do weight-bearing exercises, you can do things like chair yoga and using resistance bands or weights to also get benefit.
Yeah.
There was a doctor that is a yoga practitioner, and he came up with it's like a 12-minute yoga regimen that can be done. There are multiple modifications that can be made, including chair yoga. And it's a sequence of yoga postures that have been shown to increase bone density. And so I will put some information of that in our show notes.
That's a great idea.
But, somebody might think like, oh, I'm going to go hop on my bicycle. Is bike riding okay?
No, strangely enough, especially kind of the Tour de France folks, the people who go a really long way on a bicycle, long distance bikers in general have lower bone mass, not higher bone mass. So it's not just the muscle mass. I mean, you can swim, you can bike, do that to build muscle and stay fit, but without that kind of jarring or tensile kind of mechanical stimulation through yoga, through other means, or having that vibration through walking even, without that, the bone doesn't get the signal that it's needed.
So cross train. So keep swimming, keep riding your bike if you love it, but add something else in to focus more on bone. And another important thing with exercise is maintaining balance, because as you get older, after treatments with neuropathy and, other things that can happen as the result of cancer or cancer treatment, there are issues with balance. And so the goal is to prevent falls, and if you are to fall, to prevent fractures.
That's a really good point. Yeah, because it's better to bend than to break. If you have good balance, you may not fall in the first place. If you are limber enough, you can fall in a, healthier manner. And half of bone is collagen. So we're talking all about these minerals and stuff, but it's really only 50% of the bone. The other half that doesn't show up on a DEXA scan is collagen. And that's what gives it some flexibility. I mean, I don't know if you've ever seen a child take a fall in slow motion, you can see them actually bounce. Where as adults,
I have never watched a child fall in slow-mo.
Oh, okay. Well, it's kind of one of those things in medicine that they use to, reinforce the idea that growing bone and less dense bone is much more flexible. As we age, we lose flexibility, but doing something like yoga or stretching, those kind of things that keep us limber, I think is really important because, one, you don't want to fall in the first place, but if you do fall, you want to take a good fall, not a bad fall.
And so you mentioned collagen, going back to the supplement section. I mean, would taking collagen be beneficial to someone who's trying to prevent bone loss?
It can be. It can be. I do that kind of selectively, depending on what their diet looks like. Amino acids are involved in collagen production, and what type of cancer history they have. Because
I think that's an important part, right? So It's not like collagen supplementation would be safe for anyone who's had a history of cancer.
No, there's certain cancers that we know prefer certain amino acids. So we don't want to give amino acids to people who have a type of cancer, a subtype of cancer that prefer amino acids as their fuel source. So what comes to mind right away is triple negative breast cancer. I may not give collagen to somebody with a history of triple negative breast cancer, knowing that that particular type of cancer can use amino acids as its own fuel source.
So just what's good for one person who may have had one type of cancer might not be good for you if you've had a different type of cancer. I mean, we're all individuals. And so the way that we treat our patients is on a person by person basis. It's all individual. So just use caution before starting any supplements.
Yep. Always. So we discussed bone physiology, the osteoclasts and osteoblasts. We covered the Pac-Man osteoclast. We covered risk factors, and we covered some minerals that we recommend for people to make sure they have plenty of. And then we went into some hormonal causes and how the hormones function at the level of the bone building and remodeling. And then finally, we covered exercise and the idea that muscle is an endocrine organ.
I think that's it.
That's everything, right?
I think that's everything.
We had a lot today.
We did, but I feel like it went more smoothly. We're learning. We are learning, people.
Only one way to go. We will only get better.
Well, if you know someone who will benefit from listening to this episode, please share it. I think this one is one that, like you said, initially goes beyond just cancer and cancer support. And yeah, check us out on the social media, and I'll put up a link for our Spotify again.
Sounds good. And our website has all of the podcasts on there as well.
And also, I've put a couple posts up. I guess I should send out our first update as to what is new on the website. But yeah, go check it out. If you aren't already signed up, you can sign up on the website, subscribe to get updates.
And the website is very easy to remember because it's just thecancerpod.com.
That's a good point. We should mention how to find us.
We try to keep it simple.
And so on that note, I'm Dr. Leah Sherman.
And I'm Dr. Tina Kaiser.
And this is the Cancer Pod.
Until next time, take care.
Thanks for listening to the Cancer Pod. Remember to subscribe, review, and rate us wherever you get your podcasts. Follow us on social media for updates. And as always, this is not medical advice. These are our opinions. Talk to your doctor before changing anything related to your treatment plan. The Cancer Pod is hosted by me, Dr. Leah Sherman, and by Dr. Tina Kaiser. Music is by Kevin MacLeod. See you next time.